Good morning, everybody. I am the next one up here, and today I'm going to talk to you about our diabetes program, our inpatient diabetes program here at Houston Methodist Willowbrook, and get you a little bit up to speed because we take diabetes care very, very seriously here. We're very proud of it. And let me take you through the slide deck a little bit. So we're going to go over today and look at the benefits of glycemic control, look a little bit at our insulin and our different ones that are on formulary, talk a little bit about onset, peak, and duration and actions of the insulins, and how appropriate nursing interventions are associated with the care of patients with diabetes. So my name is Mary Ann Strobel. I am your professional practice leader for diabetes. I am a certified diabetes care and education specialist, and I am a nurse. So I like to say that I'm a nurse because I know sometimes a lot of the questions may have to do with the diet, and unfortunately, that's not my expertise. I can speak on it in general terms, but if the patient has a lot of diet questions, then we do have wonderful inpatient clinical dietitians who are better suited for the diet questions. But my role here is to kind of be the overwatcher for our glycemic control for the whole hospital. So I do look at different nursing units, and if we are meeting our goals for our glycemic control, and then I'll be talking with managers and directors and other department leaders trying to figure out how we can do some improvement. So I did give you on this slide as well where I'm located. I'm on 6 West. I do work the 5 days a week, so I'm usually always here. And there's my phone number, and there's my email. And the reason I want you to know about contacting me is because one of the best ways to use me, since I am the only certified diabetes care and education specialist here for the inpatient, what a good way to use me is to give me some good communication if you see anything that we could look at improving in regards to glycemic care. So you can email me. You can certainly leave me a voice message. Some people don't like to be identified. They want to tell me that something looks like it needs correcting, but they don't want anybody to know that they're giving me that information. So I gave you the location of my room. Sometimes I come into this little office in the morning and people have shoved papers under my door with information on them. So however you want to reach out to me, if you call on the phone, you can disguise your voice. I don't really care, but I do want to hear if there's something that we can do to improve, because that is a big part of my job. So I just want to talk a little bit about, overall our different types of patients and their challenges with glycemic control. And I'm going to ask you all a question, and you can just shout it out. Is hyperglycemia good? Is high blood sugar good? I think you're all muted. Can you unmute yourself?
No, it's not good.
No. What parts of the body will out of range glucose affect? Is it one part of the body, or what do you
Every
think?
system.
Thank you. Yay, that's it. That's the answer. Every single part of the body is affected by glycemic management. And so if you want to know where I'm involved, I'll tell you everywhere, absolutely everywhere. And where will you find patients with diabetes or glycemic challenges? Absolutely everywhere that you're working. Here in Houston, we have even more diabetes than some other places. And that's evidenced by the fact that we have a global initiative called Cities Changing Diabetes. I think we've got about 20 cities involved globally right now. When we initially started, we only had a handful of cities involved, and Houston was at that time the only city in the United States involved in this global program. So if that gives you any inclination of how much diabetes is in Houston, if we were the only city representing the United States in the beginning at this initiative start, then that kind of tells you we're in the hotbed of diabetes right here. We're kind of at ground zero. So I can guarantee you that on any given day, you will absolutely have a patient with diabetes or with glycemic control concerns. So that being said, I love working at Houston Methodist because Houston Methodist overall, and it also goes with their glycemic programs, is going to be proactive rather than reactive. Houston Methodist is always looking to be unparalleled and to always look to how to do the right thing from the beginning rather than trying to correct a problem. So that's what we try to do with our glycemic control as well. We want to more closely mimic the body's pancreatic insulin secretion. And that being said, that means that we're not going to be relying on something that we used to call the sliding scale management of patients with diabetes. So just think about it. I don't know how many of you are coming from maybe hospitals where you were predominantly using the insulin sliding scale to treat hyperglycemia, but you know what happens with that. You wait till the patient gets high, you hit them with insulin. Sometimes they get too much and then they get low. Then we wait to get high again. Then we hit them with insulin again, and we play what I call ping pong all day long. That is very, very, very hard on the body, and we don't want to do that. So we are going to use a long-acting insulin here for most patients, along with a rapid-acting insulin to usually cover meals and also correct higher sugars. So we would do that together along with using the long-acting insulin. Sometimes if the patients, of course, are not eating, then we would just be using the rapid-acting insulin in a correctional fashion. So what are the numbers that we try to keep our blood sugars at here for our hospitalized patients? Well, pre-meal, about 100 to 140, and no higher than 180 the rest of the day. So, of course, you know, there may be times when that's not happening, but we try to, as quickly as possible, get back within that range. Our physicians are very good about, you know, looking at these blood sugars and trying to work to try to get the patients in that range. Now, on this slide, the items in yellow highlight are the insulins that you will see most often. They're on our formulary. It doesn't mean that you will never see some of the other insulins. Sometimes patients even bring their own insulin in, and we do have a policy for medications brought from home. But for the most part, you're going to be working with these insulins most of the time. The reason I wanted you to see this slide is because if you are not that familiar with the different insulin's onset, peak, and duration, this is something that you probably want to get a little bit refreshed upon, because we're going to be doing a lot of glycemic management here at this hospital. And why do you think it's important to know like when the insulin is going to peak? Why do you want to know that? Anybody can answer.
So the patient shouldn't drop
Very
eat.
Absolutely. Yeah, like I always try to give an example of, you know, if you give your patient a certain type of insulin, let's say we're going to give them NPH insulin and we see it's going to peak in 4 to 14 hours. That's a pretty broad range, right? But we know that definitely it's going to be starting to peak around 4 hours. We know the onset is 1 to 4 hours. So somewhere within that 1 to 4 hours, definitely, you know, their insulin is going to start to work and even start to peak. So let's say that patient hasn't been getting out of bed and all of a sudden PT shows up and wants to walk the patient down the hallway. You know, you've got to watch, right? Because that patient with that exercise of walking down the hallway could actually suffer a low blood sugar because their insulin might be peaking at the same time that they're trying to do this exercise. So yeah, it's really important to keep you know, your mind on how these insulins are working, because some of them don't work, you know, immediately. Where if you do something like the Lispro, here we use something called Admelog, which is insulin Lispro, no different than Humalog. It's just that it comes from a different company. But we know that that starts to work in about 10 minutes. So if you give that patient their insulin and their food doesn't arrive, and you're given that insulin solely to cover that food you're anticipating they're going to eat, they could also have a low during that time. So I do want you to refresh yourself about the different insulins and the onset, peak, and duration. If you'd like a copy of this slide, we can ask Vina or Sue to see how they can furnish that for you. So what is basal insulin? So basal insulin is background insulin. It's long-acting insulin, and it doesn't really have anything to do with food. It is there as the insulin to act to maintain homeostasis. We know that the job of insulin is to push sugar from the bloodstream into the tiny cells of our bodies. And if we don't have insulin available, the sugar is going to stay in the bloodstream. It's not going inside the cells. So that's when we can get into lots of problems. And you all know the condition that starts with D and ends with A that happens if patients don't have any long-acting insulin. That their body isn't making any insulin, and then if they're supposed to get long-acting insulin and we would hold it, what is the name of that condition that starts with D and ends with A?
DKA.
Absolutely. Yeah, so we don't want our patients going into DKA. So, if the patients take long-acting insulin at home, and you see that, and the patient isn't ordered on long-acting insulin here, please have conversation with the attending physician. Then we use this bolus or mealtime or correctional insulin, which is going to be our Admelog, our insulin Lispro, and that's going to be to cover any food that they're eating or to cover and correct high sugars that are outside of the range. So sometimes patients who are eating will get a correctional insulin as well as a scheduled insulin. So what types of patients should we be aware of that may have hyperglycemia, high blood sugar? So we know that, right now we're dealing with a lot of steroids, right? And a lot of stress response due to significant illness. So right now we're having a lot of challenges with high blood sugars or hyperglycemia. We also have patients that have not been eating and then all of a sudden they start eating. So all of those things combined can definitely contribute to some high blood sugar levels. So we could use this corrective insulin. We don't use sliding scale wording. We call it corrective insulin because that's really what it is. But it is written in this stepped format, and it is supplemental insulin that can be used to try to bring a blood sugar value down from a higher range into an acceptable range. And like I said, oftentimes patients will be getting this correctional insulin and sometimes also be getting a scheduled dose of this rapid acting insulin in order to cover a meal. And then you would give both doses together in one syringe. So, for example, the patient may be getting a correctional dose of 3 units of this insulin Lispro before the meal, and that's just to correct the high they're at to bring them back in range. So that would be 3 units. And the doctor may have ordered 5 units to be the scheduled dose to cover the carbohydrates in the food the patient's going to eat. So if they had scheduled 5 units and 3 units to correct, we would be giving them a total of 8 units. Does anybody want me to go over that again? No? Okay. Going to move on. So this is just showing you what the doctors see when they're putting in the orders. They can see this is a little clip from an order set, and the doctors can kind of see what is the correctional dosages, how much they're going to get depending upon the different range they're in. But one thing I wanted to call attention to for you to look at over here is that it says that greater than 300, even though you can see there is a dose you can give, it tells you how many units. What else are you supposed to do if your patient is greater than 300?
Call the doctor.
Call the doctor. There you go. And I just wanted you to make you aware of that, because I sometimes find that people get busy and they forget to do that. They do give the dosage, but they do sometimes forget. So when should you give pre-meal insulin? Maybe given about up to 10 minutes before a meal or immediately after a meal if oral intake is uncertain. And we can go over more of this, when I see some of you for our meeting plans. But I just wanted to get you a little bit accustomed to what we do here. So you see that we've got some very tight windows of when we should be administering our insulin. And also, we shouldn't be using blood sugar values that are greater than 30 minutes old. We can kind of get by up to 60 minutes, but if you have a blood sugar level that is certainly greater than 1 hour from the time that you're going to make a dose decision for giving insulin, you should get a more current blood sugar. So even if you had a blood sugar done anticipating you would use that blood sugar as the value to give an insulin dose, if it's more than an hour old, you should go and recheck that blood sugar. So again, like I said, we don't hold any doses of the long-acting insulin. Here we use glargine Lantus insulin, but you shouldn't hold long-acting insulin because it really has nothing to do with food. It does have to do with maintaining homeostasis. However, you will see in your orders that if the blood glucose is less than 80, you do have to call the provider for a possible dose adjustment. So you can hear from everything that I'm saying, it's quite complex, and there's an awful lot of things in your diabetes related orders. So it would be a good idea as you start to work to really get more comfortable with diabetes and glycemic control, and so that you don't have to keep looking and reading the fine print on all the orders every single time. Not that you shouldn't read it, you should always read your orders, but get some more familiarity with it so that you're feeling a little bit more confident and efficient. And I'm not going to go over this in too much detail. This is just showing you that the doctors have some very good order sets. Our order sets are created by the Diabetes Action Council, which is headed up by our chief endocrinologist for the system. We do meet once a month, and I do sit on that council. And the order sets are standardized for the whole system. So it's very, very nice. And anytime we do have any order sets coming out for glycemic management, you can be assured that many eyes have looked at it and many experts have helped to create it. So you can feel very confident in it. So as far as hypoglycemia, low blood sugar is concerned, we don't want that any more than we want high sugars. And we know there's certain conditions that make patients more prone to low blood sugars. And that, of course, would be anyone with renal failure, especially our dialysis patients, liver disease, malignancy. These are just a couple of that I wanted to bring up. Certain medications certainly can throw patients into being more prone to getting low blood sugar, but also know that especially now when we're discontinuing steroids, if we don't back down on some of the insulin dosage, you're going to also have hypoglycemia with your patients. So just make sure you're keeping a good watch on the blood glucose control and continue to have what I call glycemic conversations with your providers. Again, this is just showing you what the doctors see when they put the orders in for hypoglycemia, but you can see how detailed these orders are. And so I do really, really recommend that when you get up on the nursing units, you have a look at these orders and you get much more familiar with them, because the chances of you having to respond to hypoglycemia is pretty great. And in addition to that, while this is an order in an order set, if you do not have hypoglycemia orders, you are still expected to treat hypoglycemia, because our System Diabetes Action Council has actually created a nurse-initiated protocol. So if you are taking any notes while I'm talking, I can tell you the name of that policy. It is PCPS 142, adult hypoglycemia. And I do recommend, if you get into the computer to look at any of our policies, that you do look over that one. So as you can see, our hypoglycemia orders for the nurses are very, very detailed. So they can even look confusing. This is how you might see it on your Epic screen for your nursing orders. And it can be very, very confusing to read all of that. It's a big, long paragraph, but I do want to tell you that in your orders, you're also going to find a reference link that's going to actually take you to something called an algorithm. And in that hypoglycemia algorithm, you're going to be able to more clearly see what you're supposed to do to treat low blood sugar, depending upon if it's the initial time, if it's the recheck, or the third recheck of that blood glucose. So if you kind of just follow the arrows and, answer the questions yes or no, it's going to bring you all the way around to what you are supposed to do. So you should have also one of these algorithms hanging up, hopefully in your med room. So you might want to take a look at it. This is just another way that you can look at your nursing orders. You can open up something in a clipboard, a work list clipboard. So have your nurses that are going to be helping you up on the nursing units to get acclimated to show you how to use some of those different views. I'm not going to go into these in detail. I'm going to let you look for it in your charts. And just know that, again, they're very detailed, but they're very, very complete. One thing I do like to remind nurses about is don't forget to check your early morning labs, or anytime you're working and you have labs. Right here now at Houston Methodist, system-wide, you will only get a call from the lab if the blood glucose is less than or equal to 45 or greater than 400. So, if your patient is outside of, that range, that's of course critical values. But if your patient is 46 with their blood sugars, you're not going to get a call from the lab. And I don't know, 45 is not good, and I don't think 46 is any better. So I would just be very, very when you're working to make sure that you are checking your labs. This is just different views of, the hypoglycemia orders, just different ways that you can try to carve it out so you can read it and understand it better. So I told you a little bit in the beginning about what I do as far as, overseeing glycemic control. I also will see some patients, although I will see a very small amount of patients. I am not really the diabetes educator for the hospital, although sometimes doctors consider me to be that, and I'm happy to step into that role as well. However, that is not my primary job, so because I am a scarce resource, I am allocated to seeing, really, truly very unstable patients. Of course, insulin pump patients, I will come by and get involved in that case as well. And then, other situations and patients that are very complex, that's a good way to use me. And then a better way to also use me is to use me, like I said, to consult me. Sometimes I have nurses that'll give me a call and they'll say, hey, can you look at my patient's glycemic control with me? And together we will look and we will see if there's something there, and I'll give a recommendation, maybe ask the nurse to call the doctor and, tell them this or that. Or sometimes we'll go to the clinical pharmacist and we'll work with the clinical pharmacist, and then we'll go to the doctor together. So that being said, who teaches patients about diabetes at Houston Methodist Willowbrook? Well, everybody. We do have a diabetes champion group. We call the Diabetes Resource Clinicians, and they are clinicians of interprofessional. They can be dietitians, certainly nurses on the nursing unit. It can be someone from PTOT. We do have representation from almost every department. And so it's very good because we all have a different perspective on the care of the patient with diabetes. But for a lot of the usual diabetes education, we do have that are available, and nurses will be asked to teach patients about diabetes at the bedside. Sometimes you'll see that I've even put an order in asking you to do that or to teach the patient how to give themselves insulin. I'm not going to go over that today, so you'll see that there are, in the orders where physicians will sometimes will consult me on these very difficult cases. Let me keep going here. Now, this is important. This is called the Epic Glucose Screen. And if you don't already have this applied to your profile in Epic, when you get your Epic training, you're going to want to apply this to your profile because this is going to graphically show you how your patient is doing with their blood sugar levels. So, for example, there's different things I can learn from this screen. I can hover over a certain colored dot, and it can tell me what a lab glucose was. I can also see if the patient went with some low blood sugar or went with some high blood sugar. I can see if anybody treated the patient with IV dextrose or if the patient received certain insulin dosages or how much the patient ate or even what their A1C is. So I do recommend that you find out how to apply this Epic glucose screen to your Epic profile because I'll tell you what, it'll really save you a lot of time. Don't forget to look for your A1C results. As you can see, this is a real patient and they had a 15.7 A1C. Does anybody know what is a recommended controlled A1C for a person with diabetes?
Less than 6, maybe?
Yes, 6.5 to 7, you're right. So someone coming in with a 15.7 is really coming in out of control. So again, if I get some of the consults, I will always make a progress note, a consult note on the chart. And then if it's a patient I'm not going to see, I may be giving that and ordering it back to the bedside nurse. Sometimes I'll write sticky notes on the chart. And as far as our champions, they're called, again, diabetes resource clinicians. This is just telling you a little bit about what they do. And basically, they're our communicators. They are experts in knowing about diabetes care, so they can communicate that to their colleagues that they're working with. And then they can bring information back and forth to their unit about glycemic control of our patients and what's going on with recommendations from the rest of the system. We have a lot of fun as diabetes resource clinicians. This was a big event we had back in 2019, which was a beautiful, fun and interactive health fair for our hospital employees and staff. And we did it with the theme of the Pirates of the Caribbean. And all of the departments got involved. They made posters, and each poster also had to solve puzzles like you would solve in an escape room. So it really played into critical thinking and used all of the different learning styles. This is just showing you where the nursing sticky notes are at, that you might find some information. This is how to chart your diabetes education in Epic. You'll learn all of this. This is showing you about insulin pumps. Like I said, I will see insulin pump patients. I will not make changes to their insulin pump settings, but I will work with our inpatient endocrinologist consultant on these patients. Patients must be able to self-manage their pump in order to continue using their insulin pump in the hospital. And they will need to sign some agreements, and we will need some special orders. So more to come on that. We get patients in with insulin pumps. Not too often. We seem to go in waves, and sometimes we'll have 5 in the house at one time. And then recently, probably for about the past month, I haven't had anybody. This is also the last couple of slides just telling you that we do have a really wealth of information, and I need to change this because it's incorrect on how you access it. But I do want to tell you we have diabetes resources on the intranet site. They are available under diabetes education. We do access them from nursing. And when you get into this diabetes education intranet page, you will see that we do have information for patient care, for prescribers, how to link them to outpatient diabetes and community resources. So when I meet with you again, we can go over this a little bit more on how to access them. You can certainly ask your diabetes resource clinician champions how to access them. And these booklets are the booklets that we do give out to the patients. They are in English and Spanish. And you can, again, get them on the intranet. You can have them print out and give one to every patient with diabetes. We also have for pregnancy. So if any of you on this education call are going to be working in women's services, know that we also have booklets on the intranet page for diabetes and pregnancy. So that's all I really have for you today. I know that was an awful lot to take in, but no worries. We'll meet again before too long, and we'll dive into this deeper from a clinical perspective. Does anybody have any questions today? You're all ready to take care of diabetes patients?
Yeah.
I guess so. Okay. All
Thank
right.
you.
Vina, do you have any questions for me? I think she may have stepped away from the desk, huh? Okay, all righty. Well, I'm going to keep you here until Vina comes back. I'm going to try to call her. Oh, here she comes.
No, please bear with me. I'm sorry. I had to step away to take a call. I'll be right with you.
That's okay. I'm going to just keep you here. So I do need to hear some diabetes questions. Let's keep talking about diabetes till Vina comes back. I know you must have a question. It's not from, of course you just got here, but something in your career in the past that you've either had a question about, or maybe just tell us a story about something that you learned, or something that worked well. And want to share? You're shy? Don't be shy.
So how about the new injectables that they have? It's not insulin, but it's they take it weekly. I'm forgetting the name of the.
They're really good. They're called GLP-1s.
Yeah.
Yeah, GLP-1s are actually another hormone. It's a gut hormone. And our bodies naturally produce these hormones. They work along with our entire glycemic control system. Some of the names are Trulicity, Byetta, Bidurion, Ozempic. Ozempic's got a really good commercial out there right now. So yeah, they're weekly injectables. They're not insulin, and what they do is they work to help your body with the normal process of maintaining glycemic control. So what happens is let's talk about it from the perspective of eating food. So you eat food, and right after you start to eat, your blood sugar starts to rise as some of the food breaks down into sugars and gets into the bloodstream. And then your body needs to respond by, of course, pushing out some insulin from the pancreas. And as you have diabetes for a while, that immediate response of insulin release can actually get blunted. And one of the things that will help it continue to push out that stored insulin, move that sugar from the bloodstream into the cells of the body, is a stimulation from this other hormone called GLP. And GLP will help to also stimulate your pancreas to push out some insulin. At the same time, it'll calm down the liver from pushing out stored sugar inappropriately, similar to what metformin does. And then in addition to that, it will also slow down the digestion a little bit so that a lot of sugar doesn't dump into the bloodstream at one time. So that's how a GLP-1 works. That was a great question.
Thank you. But if our patients are taking those, so we keep that in account, right? Ordering the insulins and everything. Like I think a lot of doctors are prescribing Trulicity to their patients these days.
Yeah, what we'll have to do here is the patients will have to bring their own medication from home. If they are supposed to take that weekly dose while they're here in the hospital, I have seen physicians order that the patient can bring their Trulicity or Ozempic in and take that dose, that weekly dose here. We don't, to the best of my knowledge, we do not keep them on formulary. We may have some Victoza, which is not a weekly, that may be around, that might have been ordered. I've seen in the past, but for the most part, patients would be and we would be taking patients mostly off of that and just managing them with the Glargine and the Lispro, while they're here with us in the hospital.
So it is okay for them to be off of those and be on insulin.
Yes.
Okay.
Yes. Insulin is the management of choice for inpatient glycemic control, and that comes to us from the guidelines that are published yearly from the American Diabetes Association. They put out something called the Standards of Care. They're new each year. It is a wonderful collection of experts that work on these every year and bring changes and updates. And currently, through the ADA Standards of Care for 2021, most glycemic control should be done through the use of long-acting and rapid-acting insulins.
Yeah. So in my last hospital, we would stop the POs and start them on insulin. That's why I was asking about
Yes, you're absolutely right. We do that here too. Oral agents are discouraged. In fact, recently our Diabetes Action Council took sulfonylureas off of the formulary for inpatient use because they incur too much hypoglycemia. That was the recommendation of the ADA Standards of Care. Now, can you still have a patient on, for example, glimepiride, glipizide, or glucotrol? Yeah, you can, but it's going to take the physician to really want it, and it would have to go through a pharmacy review before you're going to see it hit the Pyxis. So we have a layer of protection so that we don't incur that hypoglycemia. Metformin, rarely do I see that. I mean, once in a while, if their kidneys are good, we'll see some metformin hanging around. And we can once in a while now see some of the newer oral agents. We'll see the DPP4s or the SGLT2s. And SGLT2s we may start to see a little bit more of. These are going to be things like Jardiance and pagliflozin, dapagliflozin. And the reason you might see a little more of those is there's been a lot of research done on the cardioprotective part of the SGLT2s as well as the glycemic control.
A quick question regarding my area of work. Do we have a protocol for people that are being kept NPO in the hospital before going for an endoscopy? Do they have a protocol of starting some kind of an IV fluid with dextrose or something?
No, not currently. We do not have that protocol in currently. Now, as far as whether or not we will get a system-wide protocol, I would say that it is very likely that our chief endocrinologist for the system is looking at that. But currently, we just implemented a perioperative pathway. The specifics of the glycemic control is still handed over to the anesthesiologist. But as far as endoscopy patients and being NPO, all we have currently is going to be to follow the perioperative pathway. And a lot of that is going to be with personal input from the prescriber. There really isn't an overall protocol.